Great, so thanks very much for the introduction and the opportunity to present. So I've got 10 minutes to talk to you, and I've got a lot of interesting things that I'd like to talk through, so I hope you'll forgive me if I go fairly rapidly. So I'm going to talk through 4 examples looking at how we've used data to help us understand COVID within cancer services, how we're trying to use data for new medicines adoption, research for feasibility, and potentially looking at variation and benchmarking between Edinburgh and some of the other Scottish cancer centres. So, it became apparent quite early on in the pandemic that increased mortality was not just due to COVID-19 related deaths, but we also saw increases in cancer-related deaths as well, in excess of 10% in Scotland over expected rates. So we were keen to understand why that was happening and react to protect the service and our patients and maintain outcomes as well as we could. Disruption can occur throughout the cancer pathway, which is often complex, from first symptoms where patients may be less willing to present to health services, through to capacity problems that may be imposed by the pandemic around treatments. So the usual three months to 1 year cycle for cancer incidence and staging data isn't really enough to help us react in the timely manner that we were hoping to in the spring. So back in March, April, we turned to what we had at hand, which is, so here we have first treatments for cancer, which we were able to use on a up to weekly basis as a surrogate for cancer incidence. And we're interested to know initially whether cancer incidence was changing, increasing or decreasing in response to the pressures that the pandemic was posing. For breast cancer here, it was reassuring. So first treatment rates in 2020 compared to 2019 were fairly consistent, even slightly higher, until, as you're aware, the national screening programme was paused, where we saw the screen detected patients fall out of the incidence, leading to slightly lower incidence rates than expected. And Catherine's already shown you the more robust audit and registration data derived incidence, which shows the more robust impact on incidence. It's probably too early in the first half of 2020 to make any conclusions about whether we saw more advanced presentations that may have been incurred through delayed diagnoses. Certainly within the first half of 2020 in breast cancer, things looked fairly comparable to prior years, but it will be interesting to see what the second half of 2020 brings to understand the impact on our patients. Catherine mentioned the chemotherapy or SACT activity data. So again, we were keen to very rapidly understand the extent to which treatment capacity or delivery was being affected by the pandemic. And we saw quite early on a fall in excess of 20% in treatment activity across Scotland. Whether that was due to reduced capacity, or perhaps more likely due to different treatment recommendations or patient preferences in light of a modification of the balance of risks and benefits when faced with the additional risks of COVID-19 infection in the presence of immunosuppressive cancer therapies. But what was clear is that the reductions in treatment rates were greater in the west of Scotland compared to other parts of Scotland, which we think is likely to reflect the greater pressures from COVID in that area. We can see slow recovery during the year, and this is invaluable in helping us respond and provide sufficient capacity within the SACT delivery services. We're also, our cancer patients are potentially a highly vulnerable group in the face of COVID-19 due to immunosuppressive therapies. So very early on, we worked with Public Health Scotland to get regional positive COVID-19 test data to help us understand how big infection rates were in the cancer population. And so far to date, we've seen 69 confirmed cases in patients who are on active anti-cancer therapy in NHS Lothian. And what's perhaps more valuable than just looking at local data, given the value of or necessity of patient numbers, is that we were able to contribute to a UK-wide audit monitoring programme, which rapidly gave us some information about mortality rates from COVID infection in patients on anti-cancer therapies. So moving on from COVID, one of the challenges that we face in oncology is in adopting often expensive but potentially very effective new medicines into what may well be complex treatment pathways. So here's a cohort of 350 patients in NHS Lothian with metastatic breast cancer, and you can see here the sequence of anti-cancer drugs that these patients have received. This is a mixture of community-prescribed hormone therapies and hospital-prescribed chemotherapy systems. So we think that Scotland is probably one of the only places in the world where we can produce a map of treatment, these complex treatment pathways, combining both community prescribing and hospital chemotherapy prescribing data. And being able to get at this data is invaluable, and it helps us pre-plan for adoption of new medicines, helps us understand what the likely costs are needed, and also feeding into a future modelling capacity tool which has been developed in South East Scotland. We're able to predict in advance the implications for chemotherapy capacity and treatment. A quick note on research feasibility. So we're frequently asked whether it's feasible for us to participate in clinical trials or research study. The key question is how many patients are we likely to have eligible over a recruitment period. So this is an example that came across our inboxes about a year ago, looking at, so Edinburgh was asked to participate in an international research registry looking at male breast cancer. So the key question is, do we have enough cases? Is it viable for us to contribute to this? And to work this out historically requires lots of communication amongst the 14 different health boards in Scotland to try and work out if we need to do this as a single site study, if that's feasible, if we need to do it nationally. I had a look at this in the Scrush dashboard last week, and within the space of about 10 minutes, I was able to estimate that we're likely to be able to recruit up to about 10 patients per year across Scotland. In Lothian last year, we had 2 male breast cancer patients. I was able to use my third level access to the dashboard, identify those patients and double check against the clinical records that in fact they are eligible. So once we have molecular pathology and genetics data, which defines a lot of research studies eligibility in the future, this will be an incredibly valuable resource for cancer centres trying to understand the research feasibility. And then finally, looking at variation. So there was a Health Care Improvement Scotland report a couple of years ago which identified possible variation in chemotherapy prescribing practice for early breast cancer after surgical treatment. The key question for us as a clinical breast cancer community in Scotland is that warranted or unwarranted variation? Is it real? Is it measurable? And is it affecting outcomes? To do that, we need case mix, or to assess that, we need case mix adjustment. So this is where we go beyond what a dashboard format can potentially provide. So we took this opportunity to seek approval from the Scottish Public Benefits and Privacy Panel to undertake a data linkage exercise using Scottish national data in the National Data Safe Haven, using some CSO funding specifically for this project. And in Scotland, we're able to characterise cohorts of patients and a lot of the necessary case mix variables for confounder adjustment from inpatient, outpatient data, community prescribing, and other socioeconomic indicators. So when we looked at breast cancer patients over the last 20 years treated in Scotland, we can see that the proportion of patients getting chemotherapy after early breast cancer is around 40%, fairly consistent between health boards. But actually, if you look at the 2 biggest health boards, Glasgow and Lothian, actually maybe up to 4% difference in chemotherapy treatment rates if we look at the unadjusted observed proportions over the last 20 years. Using confounder adjustment for cancer staging variables, socioeconomic factors and comorbidities in particular, those proportions adjust to essentially the same, which was very reassuring for us. And we can see if we plot the proportions of patients receiving chemotherapy for early breast cancer over time over the last 20 years, we can see that even 15 years ago there was quite a marked difference between the different networks in Scotland, up to 10%. But over time, presumably as our practice has improved and we've adopted more consistent decision-making processes, we can see we're converging over time, which was very reassuring to us. Mortality.
2 minutes, Peter.
Thanks. Mortality is easy to misinterpret, particularly in in the face of unobserved confounding. And indeed, without adjustment, looking at all-cause mortality in this same breast cancer population, we can see that there are subtle differences between health boards, but when we adjust for confounding factors, particularly comorbidity, these hazard ratios converge, which again is reassuring. You can learn a lot more about this program of work on the following links. So that's all I wanted to say. Thank you to everybody who's helped me pull together those slides in this activity.